So the first question for today is, which of the following is implicated in hemolytic uremic syndrome? Your options are enterohemorrhagic E. coli, that is EHEC, pneumococcus, factor H deficiency, or all of the above. So which according to you is implicated in hemolytic uremic syndrome? Good evening, everybody. I'm Dr. Abhishek, your mentor for these sessions, these MCQ live sessions by Medico Apps. And this is the 14th session in a row. This week we took three sessions, day before yesterday, and today. All these sessions are happening in the evening, and it's basically inspired by the fact that many students keep coming and telling me, sir, whatever you teach through MCQ, we remember it for a very, very long time. And even the theory portion, when you teach it through an MCQ, we remember it for a very long time. So all these sessions are based on questions which have actually been asked on in various exams, in various previous year exams, and I have tried to take those questions along with the relevant explanation so that each of these get into your mind. So for anyone who is attending these sessions for the first time, make sure that you hit the subscribe button and put in the bell notification so that whenever I go live, you can get a notification. You can attend it live if you are free, and even if you are not free, you can come back and attend it later. If you like this session, give a session a thumbs up, share it with your friends, and if you have any follow-up question on this particular session, or if you have any suggestion, you can put it in your comment. So this was our first question: which of the following is implicated in hemolytic uremic syndrome? So all of you can see the live chat button. You can put it in live chat button, in all of you. What is the correct answer according to you? So we know that this is definitely implicated in hemolytic uremic syndrome. However, even pneumococcus, because it produces neuraminidase, even these pneumococcus has been associated, and factor H deficiency. All these three are actually associated with HUS. The most characteristic association is with the EHEC, the SIGA toxin or the verocytotoxin that it produces, but all these three are implicated in HUS. So the correct answer will be D, all of the above. Let me tell you, a little about hemolytic uremic syndrome, because again it's a very high topic. So let's talk about it. So if you see the word itself, hemolytic uremic syndrome. So the word itself describes the clinical features. So hemolytic means there is hemolysis. Okay, we will see what kind of hemolysis happens, but remember there is some hemolysis. Uremic means there is uremia, so there will be features of acute kidney injury, okay, syndrome. So this is hemolytic uremic syndrome. So what is the etiology? What is the causative, causation of hemolytic uremic syndrome? So the first and the most important association is with the SIGA toxin, okay, also called as the verocytotoxin, which is produced by E. coli 0157, okay, also called as enterohemorrhagic E. coli. So this is the most important and most common association. However, we have seen that even pneumococcal infection, because they produce certain enzyme uramidase, and it is this enzyme which can cause the complement activation. Both this toxin as well as this enzyme uramidase, both of these will cause complement activation, leading to hemolysis. Okay? Hemolysis. Very importantly, in the blood vessels, it will cause hemolysis, and when we talk about kidney, there it will cause acute kidney injury, and that will present with scanty urine and other features. So this is the pathophysiology. Now remember, there is a very, very important difference here between those cases which are caused by SIGA toxin and those cases which are caused by pneumococcus. Now, when it is caused by SIGA toxin, we will not give antibiotics. We will not give antibiotics. However, when these cases are caused by pneumococcus, antibiotics becomes the treatment of drugs. Is it clear? So very very important. Why? When it in a case of enterohemorrhagic E. coli, when we give antibiotics, what will happen? It will lead to the death of the E. coli and further more release of the toxin. Okay. Whereas in pneumococcus, it is the enzyme. So when the bacteria dies, the enzyme will not be active. So in that case, the treatment becomes antibiotic. And the third set is when there is, and that these cases are called as atypical hemolytic uremic syndrome, and these are caused by complement dysregulation. Okay? And complement dysregulation, when we say, it can be due to factor H, factor I, complement factor B, any one of these deficiency. The most common, okay, the most common in this case will be factor H deficiency. But remember, these are atypical hemolytic uremic syndrome. Is it clear? So all these three will be implicated. So Shiga toxin, pneumococcal infection because of the release of neuraminase, and the third is factor H deficiency. All these are implicated in your hemolytic uremic syndrome. So how does the patient present? What is the clinical feature? So what is the age of the presentation? Generally, it will be a child. Now, this is very important because a very related disease is TTP, where the patient, the age profile is adult. So thrombotic thrombocytopenic purpura will have similar clinical manifestations as HUS. Similar. I'm not saying same. Similar. So one thing is we can easily differentiate between TTP and HUS based on the age. So here it will be generally an child who has presented with acute gastritis. Okay, gastritis. You gave him a course of antibiotics. What happens after 7 days? So he has taken antibiotics, and after 7 days, suddenly he is having pallor. Why is this pallor? Pallor is because of the anemia, hemolytic anemia. Okay, and then also you will start having scanty urine, which is a representation of your acute kidney injury. Okay, and you might think that the patient may be having some kind of reaction to the drug. Also, the relatives may also complain of that. Remember, a very very characteristic feature is fever is absent or not seen in hemolytic uremic. Fever is not seen in cases of uremic hemolytic uremic syndrome. What about CNS features? Okay. So CNS features can be there, but they are not very very characteristic. So it can be seizures. Okay. Then you can also have encephalopathy. Then you can also have agraphia. The patient is not able to agraphia. So CNS features can be there, but it is not very very characteristic, right? And lastly, when you do a platelet count, what will happen to the platelets? The platelets will be okay. So thrombocytopenia will be seen in these cases. So hemolytic uremic syndrome. This is how the patient will present. Very very important, and let me mention it here. Very important from exam point of view. What is the cause of non-thrombocytopenic purpura? Can anyone write in the comment if you know the answer? So here we see that this is thrombocytopenic purpura. Okay, because the thrombocytes are decreasing, and there will be bleeding manifestation or platelet because of those and purpura formation. What is the cause of non-thrombocytopenic purpura? Anyone? What is the cause of? You can write it in the comment. What is the cause of non-thrombocytopenic purpura? Very very favorite questions here. Typically, the purpura is seen on the extension aspect. I'm giving you another hint. The extension aspects of the body. What is that? So remember, Enoch squalene purpura is the cause of non-thrombocytopenic purpura. Is it clear? So this is all the clinical manifestation, and as I have told you that even when it is related to the pneumococcus, the only thing is how do we diagnose it? What is the workup? So we can do, the blood examination, the peripheral smear, where you will see that there is schistocytes, that is fragmented RBCs. There can be, cytopenia. You can do a urine analysis for AKI. So, we can do the general test, and we'll come to the conclusion that we are having a patient of HUS, primarily clinically, as well as some routine tests. How do we manage this patient? So as already told, if it is enterohemorrhagic E. coli, then we will not give antibiotic. Okay? If it is due to pneumococcus, we will give antibiotic. Plasma exchange is not very helpful in these cases. Okay? Plasma exchange or plasma pheresis is not helpful. Remember this, because there is no antibodies. So this is not helpful. Just because it is not helpful. So antibiotics, depending only if it is because of pneumococcus, then only it will be helpful. Otherwise, it will not be. What will be helpful is plasma infusion, or a new drug which has been approved is ecluzumab. Ecluzumab. Okay. You can also give packed RBCs for the anemia component, and you can go for hemodialysis depending upon the degree of the acute kidney injury. So this was the most important points about hemolytic uremic syndrome. So before we move forward, I will just like to remind you about our daily WhatsApp update groups. And here I personally send updates to all my students. So these are free groups to join, and there I say share concept card, daily short videos, quizzes, master classes. Master classes are longer classes, 10, 15, 20 minutes classes. Then all these live sessions, the notification will be sent there. There will be free PDFs and mini courses. And if you want to join, you can go to this URL of medicoapps.org/groups, and you can join a first year group, a second year group, third year group, final year intern group. And based on what group you have joined, you will keep getting the updates. Okay? And this is only an admin post group, so you will not be able to post anything, but also it is designed in such a way so that you should not be getting only good morning, good evening, good night messages and forwarded jokes. It's purely a daily update group, and if you join this group, what is going to happen? You will be feeling motivated about studying, because the daily very critical and important updates will be sent. So this is the next question for today. A 32-year-old female office worker presents with blurred vision, which gradually worsened over a course of week. She experienced pain upon movement of her eye and noticed double vision. She has no significant past medical history. However, about 3 months back, she suddenly experiences numbness and tingling in her left leg, which gradually progressed and over a period of time. Okay, the sensation extended up to her waist, causing difficulty in walking and balance issues. The symptoms persisted for a week before gradually subsiding, and the MRI of the brain is seen. So, what is the diagnosis? Anyone? Can anyone write in the comment? What do you think will be the diagnosis for this particular case? What do you think will be the diagnosis for this particular case? Is it an early onset Alzheimer's disease? Is it multiple sclerosis? Is it B12 deficiency? Is it transient ischemic stroke? Now, let's rule out all these options one by one. So, here you definitely see. So, do in Alzheimer's disease you see blurring of vision, or this? No. So, this we can really rule out. Let's talk about vitamin B12 deficiency. Okay. Again, paresthesias and all can be seen, but blurring of vision is not seen in your B12 brain. Transient ischemic attack. Now, transient ischemic attack can be presented, okay, but transient ischemic attack, the reversal of the symptom generally happens in less than 24 hours. And here, what is happening is a symptom is coming, it is staying for some time, and it is progressing. And then after some days, it is diminishing and it completely goes away. Okay? So, hence, the only option which is correct is multiple sclerosis. And in the CT also, we can see periventricular enhancements. And what is this periventricular enhancements called as? Can anyone tell me? This, yes, very good. This is Dawson's finger. This is Dawson's fingers. Finger-like appearance is there. Periventricular enhancement, because in multiple sclerosis we know that there is an increase in the blood-brain barrier permeability, and also contrast is taken up increasingly, leading to this enhancement. So this is the correct answer is multiple sclerosis. Let's look at some of the clinical features, important clinical features of multiple sclerosis. Let's look at some of the important clinical features of multiple sclerosis. So, one very the most common presenting feature, the most common presenting features of multiple sclerosis patient will be sensory symptoms. Okay. So, what kind of sensory symptoms are we talking about? So, there can be paresthesias, as in this question. There can be, if the spinal cord is involved, if the spinal cord is involved, then you can even have a sensory level. Like in this case, also the patient was saying up to the waist, and then above that it was there. One another very characteristic finding in this multifocal variate intensity shifting pain. Now this is very interesting. The patient today will say that he has a pain in hand, okay, and then the pain disappears, and after 3 days he will have a pain in the elbow. So, as if the pain is shifting from hand to elbow, and it will be very difficult to diagnose this patient also if they keep giving you this kind of history. So, multifocal, multivariate shifting pain. Another very characteristic finding which you will read only in multiple sclerosis and nowhere other here is basically all these symptoms appear initially with exposure to heat, or whenever the core body temperature increases. For example, the patient says that he went for a running, and after running he had the symptoms, or he went for a hot shower and after hot shower he had that symptom, or he went to gym and did some exercise and after that, or a sauna bath and after that. So such kind of symptom where exposure to heat or the increase in the core temperature actually produces the symptom, that is known by a very interesting name. Can anyone tell me? It is called as Hoff's phenomenon. Okay. Euthos phenomenon. So the moment they talk about Euthos phenomenon, you can be very sure that they are talking about multiple sclerosis. And how will it clinically say? It will clinically talk about the patient symptoms appearing after exposure to heat, or after when the body temperature is rising, as in running, taking sauna bath, hot shower. So these are the most common. Almost 36%, 37% of the cases will first present with sensory symptoms. The next set of symptom is ocular symptom. Okay. In ocular symptom, the most common is optic neuritis. Optic neuritis. Almost 36% of your cases will have optic neuritis. So, how does optic neuritis present? So, this patient also had optic neuritis, but it said there was a decrease in the visual acuity of the patient. Okay. Second, there can be also ophthalmic desaturation. What is ophthalmic desaturation? Suppose a patient sees a green color shirt or a black color shirt, so the entire shirt will look normal, and not consistent green, but some spots he may not be able to perceive. The green will be lighter. Okay? So this is a decrease in color perception. So that is ophthalmic desaturation. Okay? If you take a history of this patient, then the patient will talk about periorbital pain. Now, multiple sclerosis will have a lot of upper motor neuron lesion findings. Okay, so it will lead to the spasticity of the muscles, and that is what the patient will tell you when they will talk about periorbital periorbital pain, which means when the patient is moving his eyes, after movement of his eyes he will have periorbital pain. Very important to mention here is uveitis is not seen. Uveitis is not seen in your multiple sclerosis patient. If you have been given a history of uveitis plus optic neuritis, What is the disease which you are going to think of? Remember, you will always think of sarcoidosis. Okay? In this case, uveitis is not seen. Okay. There is another very interesting, phenomenon that is called as internuclear ophthalmoplegia. Okay. What is internuclear ophthalmoplegia? Let's say this is our eyes, and this is the innervation of eyes. So, on one side, the medial longitudinal fasciculus is damaged. Okay. On one side, the medial longitudinal fasciculus is damaged. So if the patient is asked to look on this side, okay, because this medial longitudinal fasciculus will be required for adduction, the eyes will not be, the affected eye will not be able to adapt. If the patient is asked to look in this side, both the eyes will go. So if the patient can adduct on that particular side, it can look away. But if you ask for adduction, it will not happen. So typically, let's say the left side is involved. If the patient is seeing in this direction, he will be able to do this. But if the patient is looking in a opposite direction, then the adduction will not happen. So this is called as internuclear ophthalmoplegia. What are the other clinical features? One very important thing will be the patient will talk about weakness. A weakness per se is not there, but it is nothing but a spasticity of the muscles. Okay, I've told you that spasticity is seen here, and because of the spasticity, the patient may feel very tired after walking or doing some work, and that is basically manifested as weakness. Now here one thing I want to mention is when I talk about weakness, the patient will say that earlier I was able to do anything, but now even chopping vegetables I'm feeling tired. So even doing minor work, the patient will talk about weakness. Another very important thing is for all the upper motor neuron lesions, remember there will be two key pointers they will put in the clinical case. One is Babinski sign positive and deep tendon reflexes being exaggerated. So these are the 2 points in the examination in a clinical history they will put, which should make you think in terms of upper motor neuron lesion. When they talk about lower motor neuron lesion, they will primarily talk about areflexia. Okay. Multiple sclerosis, is it upper motor neuron lesion or lower motor neuron lesion? Anyone? Multiple sclerosis, is it upper motor neuron lesion or lower motor neuron lesion? Anyone write in the comment. So remember, it is both upper motor as well as lower motor neuron lesion. We will see the mixed. Another clinical feature is your facial nerve palsy. Facial nerve palsy. Now it is different from Bell's palsy. In the Bell's palsy, even the taste sensation goes away. But here, in the facial nerve palsy, because of multiple sclerosis, the taste sensation is preserved. What about ataxia? Yes, ataxia is also seen. Ataxia can be both gait ataxia, which is due to paleo-cerebellum, or it can be truncal ataxia. Truncal ataxia is due to plaques in archicerebellum. So there can be ataxia. One another very characteristic feature which you are going to hear is scanning speech. What is scanning speech? Can anyone tell me? So suppose you ask the patient, "What is your name?" So he will say, "My name is Abhishek." So he is literally. It looks like he is looking up. He is finding words. Okay, so that is called as scanning speech. Okay, again, very characteristically seen in your multiple sclerosis. So there are some ancillary symptoms. Ancillary symptoms also. For example, facial myokemia means twitching of facial muscles. Obviously, we all will have some amount of facial myokemia, but in these patients, it's very exaggerated. Another very important ancillary sign which you have to know is Leher Mind sign. This has been asked in the examination. What is Leher-Mind sign? So when you do a neck flexion, there is a radicular pain in the legs. That is Leher-Mind sign, and it is not characteristic of multiple sclerosis. but it can be seen in multiple sclerosis. It can also be seen in your Tabes dorsalis, and it can also be seen in your cervical spondylosis. So Lehermit sign. When you flex the neck, there is a radicular pain in the neck. So these are ancillary symptoms. Whatever bladder bowel movement, both bladder and bowel are involved. Okay. Okay. Now bladder and when we talk about bladder, okay, one thing that can happen is there can be a loss of the inhibitory control. Okay. So what happens when there is a loss of inhibitory control? Okay, the patient will start having nocturnal enuresis and urinary incontinence. Okay, so the patient will not feel the urine, and the urine will automatically fall. Another thing that can happen is synergia, extrusor, spincher, dyssynergia. What is this? Extrusor spincher dyssynergia. We know that normally when the extrusor muscle will contract, the spinchers will relax. Okay, but if this spincher fails to relax when the distributor muscle is contracting, what is going to happen? This will lead to urinary retention and cystitis or repeated infection. So even bladder bowel involvement is seen. How do we diagnose? How do we diagnose it? We do galodium enhanced MRI. We have talked about periventricular lesions being shown, and that is called as dorsal finger. Okay. CSF finding is again very critical. So let's look about some of the investigative findings which we see in these cases. So when we do a workup, what is the investigation of choice? So investigation of choice is gadolinium enhanced MRI. So what do we see here? We will see here the plaques, or what we have seen in the image which was shown in the question was dorsal fingers. Another very interesting thing is when you do a CSF, everything is normal. But what will happen is there is slightly increase in the proteins. When we do an electrophoresis, anywhere else we will talk about electrophoresis of CSF. There you are going to get a oligoclonal band in CSF. So CSF electrophoresis when we do, we will get an oligoclonal band. Okay. For a smaller sized plaque or very early involvement, what we do is VEP, that is visually evoked potential. Okay. Visually evoked potential, and in that what we see is there is a decrease in the voltage and increase in the latency period when we do a VEP. VEP can find even smaller plaques in cases of multiple sclerosis. So this is the workup of multiple sclerosis. Let's look at the next question, and this will be the last question for today. A 47-year-old woman is brought to hospital by her husband with fever, headache, confusion, okay, and jaundice for one. She appears disoriented in time, place, and person. Okay. On examination, she has got jaundice, sclera, skin, purpura on the trunk, bleeding gums, and her platelet count is very decreased. Hemocrite is 24%, so there is anemia, and her creatinine is 4.9, so there is acute kidney injury. Coagulation tests are within normal limit, but bleeding time is increased. Which of the following is most likely the diagnosis in this particular case? So what will be the diagnosis in this particular? So let's look at the various options which are given. Now let's talk about DIC. Okay. So does this give you? So there is fever, but can you see a sepsis history? Because in DIC, it's like the patient is very critical, because of the infection. So we can easily rule out DIC. There is no severe infection. In fact, in DIC, the presentation will be of infection, and all these things will be secondary. Let's talk about hemolytic uremic syndrome. Now, there are two things which will clearly help us to understand it is not HUS. First of all, the age. So HUS is generally seen in children, and fever is never present. Okay, rest all the things can be seen, but here if you see the mention of fever can help us rule out hemolytic uremic syndrome. And also the age group. Hemolytic uremic syndrome is primarily seen in your children. Now you have got autoimmune hemolytic anemia and thrombocytic thrombotic thrombocytopenic purpura. Now in autoimmune hemolytic anemia, can you tell me, what is autoimmune hemolytic anemia? So in autoimmune hemolytic anemia, basically you will have antibodies which are attacking the RBCs. But do you see such drastic kidney injury in autoimmune hemolytic anemia? You see such drastically, and why should the platelets be decreasing? Okay, so again, autoimmune hemolytic anemia can be ruled out. The correct answer is your thrombotic thrombocytopenic purpura. Okay. Let's quickly let's quickly look at what are the clinical features which will, and also, you know, let's look at what are the clinical features of, TTP, thrombotic thrombocytopenic purpura. Anyone? So, what are the clinical features? So, we can remember it by FAT NRI. This is the keyword. What is F? F is A, anemia, hemolytic anemia. So all the features of hemolytic anemia, increase serum bilirubin unconjugated, LDH increase, reticulocytosis, all those can be there. T is thrombocytopenia, okay, and also bleeding. What is N? N is for neurological symptoms. Features of acute ischemic attack, okay, stroke. Here, like in this case, what are, such characteristic disoriented in time, place, and person, headache, confusion, okay. So very, very, acute ischemic syndrome like neurological features can be there. And so this is, so, and R is basically reticulocyte. So reticulocyte count will be increased. So these are the clinical features of your TTP, that is thrombotic thrombocytic purpura. And if you see that case, you will clearly know that this is a clinical case of thrombotic thrombocytopenic purpura. So this brings us to the end of our session. Okay. The next question we are going to discuss tomorrow. So before I before I end the session, let me talk about something which I keep talking in every session, and that is about revision. Revision is the biggest challenge for all my students. Whenever I talk to them over phone, whenever I talk to them, they will keep saying, "Sir, I have read it, but I don't remember it because primarily it is because of revision." And why is revision always a challenge? Because there is so much of information. Revision always is not very interesting. It's very boring. The moment you start revising, you'll feel sleep. And even if you have put in your time for revision, you keep forgetting. And for that purpose, we have created something called as concept. What is concept card? So we have created, on high yield topics, image based and flowchart information, so that you can keep, learning it in a very, very active form. You know that when we see an image, when we see a flowchart, when we see, something which is pictorial, we remember it for a very, very long time. And that is Medico Apps concept card. You can go to the Play Store, search for Medico Apps concept card, and download it and see for yourself if it is helpful for you or not. So this brings us to the end of today's session. If you are new, if you have come and watch this video till this point, I really want you to give this video a like and comment if you want to share it with your friends. And if you have still not subscribed, subscribe us and hit the bell icon. So this was all the sessions for this month. We have taken this week. Next week again I will announce. So that's why you should join our Medico Apps group. It is simply go to medicoapps.org slash groups, and there you can join any one of our first year, second year, third year, final year, intern, post intern group, and you will start getting daily updates on very, very high and important topics. So thank you so much, guys. Thank you so much for attending this.